I'm going to talk about the role of hypertension in the etiology of heart failure in Africa. Well, I don't have any conflict of interest. The outline, I'm going to look at introduction, the growing burden of high blood pressure in sub-Saharan Africa, hypertension as the foundation of heart disease in sub-Saharan Africa. We review some of the recent data that we have, and then the characteristics of hypertensive heart failure in sub-Saharan Africa, and compare it with other data from other parts of the world, and then make some recommendations, and then conclude. We know that about 50 years ago, high blood pressure was not a big problem in Africa. But today, I think it's one of the greatest problems that we have. CVD accounts for 70 million global deaths per year, and this represents about 33% of global mortality. Hypertension alone, we know, is responsible for 9.4 million deaths worldwide every year. Hypertension, we know, is responsible for 45% of deaths due to heart disease, 52% of deaths due to stroke. In 2008, it was estimated that about 40% of people above the age of 25 years had high blood pressure globally, and the number of people with hypertension rose from 600 million in 1980 to 1 billion in 2008. WHO has shown that the highest age standardized prevalence of hypertension is in sub-Saharan Africa. It's about 46% compared to the lowest of 35% in the Americas. High-income countries also have lower prevalence of high blood pressure compared to other groups. The number of people underdiagnosed or undiagnosed, untreated, and uncontrolled are higher in low and middle income countries. Now, this chart shows the data from WHO. You can see in Africa, the prevalence of high blood pressure, age standardized, is more than in other parts of the world. And this shows low-income countries compared to high-income countries, still higher there. Now, this is a paper we published last year, showing the prevalence of high blood pressure in Africa. And in most regions of Africa, high blood pressure, the prevalence is above 30% in most parts of Africa, except here in the Horn of Africa, where the prevalence of hypertension is still low. Probably if one want to have high blood pressure in Africa, you probably must have to live in this place. This is a recent publication looking at the prevalence and awareness of rates of hypertension in Africa, which was published earlier this year. And what they did was to analyze 92 blood pressure surveys between 1980 and 2013. The overall pooled prevalence of hypertension in sub-Saharan Africa was about 18% in 1990, was 27% in the year 2000, and it rose to 30.9% in 2010. And the pool awareness is between 16.9 to 33.7. The authors, by way of modeling, found out that 54.6 million people in sub-Saharan Africa had high blood pressure in 1980, and this rose to about 130 million in 2010. And it is estimated that in the year 2030, about 217 million Africans, sub-Saharan Africans, will have high blood pressure. Now, there are regional differences. The prevalence is highest in the southern part of Africa, followed by the west, and then East Africa, Central Africa. And the total prevalence, as estimated, is about 27.8. But although the highest mean blood pressure was recorded in western coast of Africa. I'm going to look at hypertension as the foundation of heart disease in Africa. Now, this paper has been presented earlier this morning, the TESOS study. But what is showing here is that over 40% of heart failure in Africa is due to high blood pressure. And this is even very prominent, especially in Nigeria and in Central Africa, that is in Cameroon. Now, this is the paper also earlier presented this morning from the heart of Soweto. You can also see that high blood pressure is quite a predominant cause of heart failure in South Africa, especially among the black population. If you separate the data between the blacks and the non-blacks, high blood pressure is quite very predominant as a cause of heart failure. Now, there is a recent study also published last year in the European Journal of Heart Failure, the Abuja Heart Study, that is in central Nigeria, shows that over 60% of heart failure is due to hypertension. This is our own study in Abeokuta, the Abeokuta Heart Failure Registry, which shows also that over 70% of heart failure in that city is as a result of high blood pressure. And what we also demonstrated is that compared to data in 1972 and in 2014, high blood pressure has become a predominant cause of heart failure in southern Nigeria. You can see that in the myocardial fibrosis, as somebody asked, in Nigeria has fallen dramatically, and the rheumatic heart disease also has also fallen as a cause of heart failure in that part of the country. Now, this is the Tanzanian study, also showing the same picture, that in adult patients over 50 years of age, high blood pressure is a predominant cause of heart failure. Even in those between the age of 30 to 50 years, it's also predominant. And even in people who are younger than 30 years, high blood pressure in Africa occasionally is seen in very young people, and it has quite a very poor prognosis in younger people. Now, I have this data from Sudan, two papers, Professor Khalil's paper. I'm sure he's going to talk more about the picture in Sudan after me. But what is showing here is that in 1961, hypertension contributed 44%. In his own paper, it fell to 34% in 1984. But in a recent work published in 2011, hypertension has also fallen to 28%, but you can see the trend in the prevalence or the of ischemic heart disease as a cause of heart failure in Sudan. I don't know whether this is true, but I'm sure he is going to clarify this. But this is the picture we have in the literature. Now, in southern Sudan, the picture is quite different. Hypertension appears not to be the commonest cause of heart failure. Rather, it's rheumatic heart disease and dilated cardiomyopathy. And I also tried to look for another study to confirm this, and I saw this paper published in South African Medical Journal, which shows also that rheumatic heart disease and is still prevalent as a cause of heart failure in Uganda, followed by hypertensive heart disease. Now, in Ethiopia, we have similar picture. Rheumatic is still prevalent, followed by hypertensive heart disease. And in Kenya, the picture, this paper was presented by Professor Ogah in ESC, shows that over 64% or about 54% of heart failure in Kenya is as a result of high blood pressure. And what I've done here is to summarize. It's a summary of the contribution of hypertension in recent studies in sub-Saharan Africa. And these ones in red are actually areas where probably rheumatic heart disease or dilated cardiomyopathy is still prevalent. In Ethiopia, in Sudan, it is more of ischemic heart disease. In rural Cameroon, a lot of rheumatics and dilated cardiomyopathy, but in urban Cameroon, hypertension is still the predominant cause of heart failure. Now, this is a sort of a summary of the characteristics of hypertensive heart failure in Africa. This is our own paper compared to the Heart of Soweto study and some other studies outside of Africa. The mean age is about 60 years in Africa compared to Europe, where you have about over 70 years or 69 years. Our patients present with severe heart failure. Previous history of hypertension is very common. Diabetes is lower compared to studies in Europe. And then history of previous myocardial infarction is quite low in Nigeria and in South Africa, but look at the percentage in Europe. And then very uncommon in our own setting in Nigeria, it's very uncommon to see coexistence of stroke and heart failure. It's very uncommon, it's quite low. It's possible that most of the stroke patients die before developing heart failure, but hardly do we see patients having heart failure as well as stroke at the same, except those who have complications arising from the heart failure, atrial fibrillation and then stroke. COPD about 2.5%. Atrial fibrillation is quite high, but it's lower than the data from Europe. Mean blood pressure similar to that in Heart of Soweto. Now, renal failure is also very common, and it's actually a poor prognostic factor in our own study. Anemia is also frequent, but also similar to data from other parts of the world. The length of stay in the hospital is also similar, and then mortality is similar, although lower than the European data. And in the European Heart Survey, most of the hypertensive heart failure patients were discharged. Now, what are the recommendations? There is need for regular and systematic national and regional data, which is necessary for policy. We need to develop more of chronic disease clinics in Africa that can handle blood pressure, because most of the patients, when they go to our usual hospitals, they are not given attention. Health insurance is quite not common in Africa, and government subsidy, we need to look at that as a way of helping most of these patients. They don't have money to buy the drugs. Basic equipment for measuring BP, especially at the primary health care level, is not existent in many parts of Africa, especially in the rural communities. There is need for capacity building in the form of training and retraining of health workers, and the use of nurse-led primary health care clinic for the diagnostics and follow-up of hypertensive patients. We also need to think about integrating blood pressure control in other control programs in Africa. And then national policy on non-communicable disease is only available in very few African countries. And then, although there is a continental guideline, but this needs to be reviewed regularly and tailored to the needs and peculiarities of sub-Saharan Africa, and also need to be evidence-based. The process of procurement and distribution of antihypertensive medication has to be standardized in most countries to avoid out-of-stock syndrome, and there must also be quality control in order to stop the flow of counterfeit medications, which is common in Africa. And then population-based salt reduction program can be effective. I know that this is already existent in South Africa, where they have reduced the quantity of salt in their bread. And I think this is what most African countries should also adopt. In conclusion, hypertension is prevalent in many parts of sub-Saharan Africa. It's a major etiological risk factor for heart failure in that part of the world. Heart failure due to hypertensive heart disease most often affects relatively young people in the prime of their lives. Patients with hypertensive heart failure often present with severe disease in Africa. Prevention as well as treatment of hypertension is key to prevention of heart failure in sub-Saharan Africa. Thank you very much.
Thank you so much, Ogah. Do we have some questions from the floor? We do, from Pim. Could we get a...
Very nice.
We're just behind you, Pim. There's a...
I always claim that my voice is so loud that I don't need this, but anyway. Yeah. No, a very nice presentation. I was wondering whether you would also have some data, because you're saying here it affects the relatively young people in the prime of their lives. Have you got any data on the presentation of hypertension at a very, very young and the children's age? Because this cannot be something that happens all of a sudden. It must develop over time. Yeah. So is hypertension already a major problem in the very, very young adolescents and that age category?
Thank you very much. What we know is that those patients, the young ones, usually the primary problem is a primary kidney disease. They present with primary kidney disease and high blood pressure. Often when they are not receiving adequate dialysis, the prognosis is poor. But we have not actually analyzed the younger patients to know the picture, but that's what I should be able to do with our own, the cohort in the registry, to look at the typical features of hypertension in young Africans.
A few more questions just down here, please.
You mentioned the commonest cause for hypertension in younger patients is renal failure. But how do you know whether the hypertension has caused renal failure or renal failure is causing hypertension?
Well, for somebody,
Because 80% of your patient is de novo heart failure, first time.
what we know is that most of those young people coming in with high blood pressure, they have CGN, chronic glomerulonephritis. That is the commonest cause in our situation when you remove other causes or maybe congenital problems in the kidneys or other stuff. But commonest cause in our own environment is CGN.
So we just have a question here and then over there.
Thank you very much for your presentation. I'm just wondering actually whether you looked at the, you mentioned that the hypertension led to heart failure. Heart failure, were you looking at the systolic heart failure or diastolic heart failure? Because the area that I come from, which is Oman, Muscat, the prevalence of hypertension is quite higher than your area. It's almost 40.3%. And we found that the hypertension, it's more correlated with ischemic heart disease, and then it comes into the systolic heart failure. And again, the prevalence of stroke is high. I don't know whether you looked at that aspect or not.
Yeah, in our own data, I didn't show most of that. Typically, our patients come with systolic heart failure, but about 30% of them, we have preserved ejection fraction. Okay. Systolic heart failure, like I said, most of them come in NYHA 3 and 4. The average ejection fraction in our patients is about 35%, 40%.
Right, so you mean like hypertension led to, you looked at the systolic hypertension more?
Yeah, the general spectrum. But in the whole cohort, we have people who have hypertension but preserved ejection fraction, which is about 33%.
Okay.
But the majority of them have systolic heart failure.
Okay, great, thank you.
And we have the final question just over here, please. Oh, one more. Good. Right.
Thank you. I saw the chart for Sudan, and it was very interesting because in the 60s, it showed that the prevalence of hypertension was around 44%, and it dropped in 2010 to 28%. I don't know if you know what this is attributed to, or maybe Dr. Khalil can help.
Yeah, what I was saying is I may not be able to answer that question because I know he's coming to talk. Whether that data is real, because I was discussing with him yesterday and said probably because it's hospital-based, that may not be what obtains in the community. And that may also be a very highly specialized hospital where most of the coronaries go to. And that could have affected the picture that we are seeing. But I will leave that to him. When he comes, he will tell us whether ischemic is really the major problem. But what we have in Nigeria, what we have observed, is that in the northern part of the country, it's not as developed as the south, but they smoke a lot over there. And they eat a lot of fatty diet there. Coronaries is higher, despite the fact that there is wide gap in development between the south and the north. That's the problem we have there. Coronaries is higher in the north compared to the south. But I think the primary problem there is cigarette smoking and the diet.
We have a few more quick questions from here.
This is just a comment on the rate of hypertension in children. There was a meta-analysis published in the British Medical Journal last year, and it has shown significantly at the children at school age that they have increased risk of hypertension and left ventricular mass at the school age from the age of 4 and 15. That's obviously in the Western world, but as we know that the rate of obesity is probably doubled in sub-Saharan Africa now.
Sure. And the final quick question, please.
Thank you for the presentation. And you mentioned the counterfeit medications. Actually, this problem is, I don't know whether you addressed it, and did you know the percentage and the effect on the development of hypertensive heart failure? Because in Nigeria, as like Sudan, I think the issue of the counterfeit is like 50 to 60%. And it is not only, these medications are not only harmless. These medications prove to be harmful and nephrotoxic and hepatotoxic. So did you address this in the...
Yeah, just a recommendation that I made. We have not had any survey to show how much of our medications are really good or bad. But what we know that there are a lot of counterfeit drugs coming into Africa, and that is not quite good for our hypertensive patients. They are not effective, and sometimes you need very higher doses in order to control the BP in most African patients.